Let's discuss some of the causes of neuropathic pain. If you have some of these medical conditions and have pain, ask yourself whether you have neuropathic pain, because the treatment is different for neuropathic pain. Once we've discussed the causes of neuropathic pain, I'll share with you what I think is one of the commonest causes of neuropathic pain. And actually, I think that neuropathic pain condition is underdiagnosed and undertreated. Let's dive in. Now remember, there are two types of neuropathic pain. There's what we call central neuropathic pain within the brain and spinal cord, and peripheral neuropathic pain within the nervous system outside the brain and spinal cord. So let's start with the central causes of neuropathic pain. It could be a stroke, post-stroke pain. It could be spinal cord injury pain, or pain after spinal cord injury. Other diseases of the central nervous system include multiple sclerosis. So these are things that affect the central nervous system that can trigger pain. We far more commonly see peripheral neuropathic pain, and that is pain that occurs not within the brain or not within the spinal cord, but from a trigger elsewhere. And the big one is trauma, surgery, an accident where part of that nervous system is affected. So painful peripheral neuropathy, peripheral nerve injury. Other causes might involve what we call laceration to the nerves, or amputation of the nerves or part of the body, and that's called phantom limb pain, and that's a type of neuropathic pain condition. Infections can cause neuropathic pain. Very common one is post-herpetic neuralgia, truly debilitating pain condition and sometimes tricky to manage. Cancer can cause neuropathic pain. The cancer surgery, remember what I've said, trauma, damage to nerves can trigger it, and this includes any form of surgery, including cancer surgery. So some people with cancer can get post-surgical neuropathic pain. Some people with cancer can get neuropathic pain because of the cancer itself, compressing nerves, compressing parts of the body that trigger pain. Sometimes it's the treatment of the cancer, which involves radiotherapy or chemotherapy. So drugs are a big cause of peripheral neuropathy as well. Certain types of cancer therapies can trigger peripheral neuropathic pain, and that's called peripheral neuropathy, peripheral neuropathic pain. The alkaloids, the vincristines, the taxanes, the monoclonal antibodies, the list of medications is unfortunately long that can trigger neuropathic pain as a complication of treating a cancer. We've mentioned trigeminal neuralgia elsewhere, and that's compression on the trigeminal nerve that can trigger neuropathic pain. So there are many causes of neuropathic pain. One of the big ones is a disc prolapse, which either causes inflammation around a nerve or can compress a nerve, and that can trigger what we call painful radicular pain. Not radiculopathy, which is pain and weakness, so the nerve malfunctions in some way, you get weakness, but painful or radicular pain, pain within that distribution of the nerve. And depending on where the nerve is compressed, at what level, you get a different type of pain. So for example, an L1 nerve compression or compression affecting the L1 nerve will give you pain in the groin. L2 nerve a little lower than that, in the top of the thigh or the front of the thigh. L3 a little lower and a little down on the side, and sometimes across into the knee. L4 the knee and lower, and L5 classically all the way down into the top of the foot and including the big toe. Not all radicular pain is compressive in nature. There are other causes of radicular pain. But these are the big causes of neuropathic pain that I wanted you to be aware of. Truly common causes, as I mentioned, are trauma and surgery. We'll discuss surgery at another point, but surgery is a trauma to the body, and depending on the type of surgery, you can absolutely get neuropathic pain being triggered. Phantom pain, of course, amputation can cause neuropathic pain. Thoracotomy, where operations are done in the chest and the ribs are expanded for a period of time during the surgery, that can injure the intercostal nerves under the rib trigger an intercostal neuralgia. Hernia surgery can trigger injury to the ilioinguinal nerve or iliohypogastric nerve, and that can trigger pain down into the groin. The big surgeries that we certainly treat with neuropathic pain are surgery on the spine, on the nerves of the spine, because they're delicate, they're protected within the spine, so post-surgical neuropathic pain, so post-spinal surgery neuropathic pain, and orthopedic surgery as well. Knee replacements, shoulder operations, or knee operations can trigger neuropathic pain. The bottom line is the body's delicate. Nerves are not meant to be injured and damaged, but they can get injured and damaged very commonly. If you've experienced some of these medical conditions or surgeries and you've got pain, you've got to ask your doctor whether this is a neuropathic pain in nature. Now what I want to share with you is what is the commonest cause of neuropathic pain, and I believe truly undiagnosed and untreated, and this is something we've all got to work towards doing a better job at, and that is painful diabetic peripheral neuropathy. What is this? Let me give you some quick insights into painful diabetic peripheral neuropathy. It's highly prevalent. It occurs with type 1 diabetes or type 2 diabetes. It probably affects up to 20 or 40% of patients, and it can be prevented, it can be treated. Let me give you a couple of tips and tricks for prevention and treatment. Number one, prevention. If you've got type 1 diabetes, you've got to have really good what we call glycemic control. So you've got to have tight control of your sugars. If you've got type 2 diabetes, lifestyle changes can be very important. So exercise, weight control, diet modification can be very good, along with really tight sugar control as well. Patients should be screened for painful diabetic peripheral neuropathy. So you should be screened at diagnosis. You should be screened every year depending on the type of diabetes that you've got. Remember, we've discussed the symptoms. This might include numbness, tingling. Neuropathic pain can affect balance, as I mentioned. It can affect proprioception, and it can start at the ends of the feet and sometimes the ends of the hands as well, and then it can gradually work its way up the body. What are the treatments for painful diabetic peripheral neuropathy? The three main medications that have been studied and approved by the FDA are duloxetine, pregabalin, and tapentadol extended release. But there are many other medications that can be used, and sometimes in combinations, which are better than a medication used by itself. And these might include amitriptyline, nortriptyline, imipramine, so-called tricyclic antidepressants. The SNRI medications, there are serotonin, noradrenaline reuptake inhibitors, so duloxetine, as mentioned, venlafaxine, desvenlafaxine. The gabapentinoids, gabapentin can be very useful if you're unable to tolerate Lyrica or pregabalin. Sodium channel blockers, which are other antineuropathic medications like carbamazepine, oxcarbazepine, or lamotrigine. In some parts of the world, you're able to use capsaicin 8%, which is a very strong preparation of capsaicin, which can be applied to the area and can give you about 3 or 4 months of pain control. If medications are not proving effective, if lifestyle modifications, if sugar control is not proving effective, spinal cord stimulators have been studied, and that includes both low-frequency spinal cord stimulation and high-frequency spinal cord stimulation in terms of managing the symptoms of some severe refractory cases of painful diabetic peripheral neuropathy. I've based some of what I've discussed on a published article which I'll share with you below, but there are some mention of pharmacological options that shouldn't be considered, and these might include opioids. These might include immediate release preparations of something called tapentadol or even tramadol. And the reason why they say that they shouldn't be considered is because the following. Use is not recommended due to the risk of serious adverse drug reaction, abuse, and other complications, and importantly, lack of evidence of long-term efficacy. So whilst it might work in the short term, there are complications and risks, and there is no evidence to suggest it works in the long term. Other non-pharmacological options might include psychological approaches, which we should consider for all people with pain. This might include CBT, mindfulness, and other forms of psychological approaches, and something called nutraceuticals as well, and this might include alpha lipoic acid, vitamin B, vitamin D, and magnesium as well.